So may I start? A very good morning to all. I am myself Tripti Maurya. I am here to present my topic that is on attentional networks, which is moderated by Dr. Priya Tyagi ma'am. Now, first we see what is attention. Attention is a patient's ability to attend to a specific stimulus without being distracted by extraneous or internal or environmental stimuli. Fan and Posner viewed attention as an organ system. Fan and Posner viewed attention as an organ system with its own anatomy and circuitry. Attentional system can be defined under functional and anatomical terms. Now, according to Posner's theory, attentional system is divided into three systems as under. First is subcortical system, that is also known as alerting system. It is the most primitive type of system. It involves the general level of arousal and alerting. Second is the posterior system, or also known as orienting system. It helps in direction of attention in space based on sensory information. Third is anterior system, also known as executive system. It sustains the attention to objects or events, select based on abstract information, switch among tasks. Now we will see. So this attentional system is divided under these three subheadings, these three systems, that is subcortical system, which helps in alerting. Second is posterior system, which helps in orienting. And third is anterior system. Now we will see the diagram of it. The alerting system is represented by this triangle, two areas. First is right frontal area and superior parietal lobe, which is involved in alerting system. Second is the orienting system, which involves the frontal field, temporoparietal junction, the pulvinar, and the superior colliculus. Third is the executive system, which involves the anterior cingulate gyrus and prefrontal cortex. Now we will see each system in particular. First is subcortical system, which is also known as alerting system. It basically involves the locus ceruleus is activated following a warning signal. Drug blocking norepinephrine will decrease alerting, while drug increasing norepinephrine will increase a warning signal. Right hemisphere involved in slower, that is toning alerting, while left hemisphere involved in rapid, that is phasing alerting. This diagram here shows this locus ceruleus part, which is involved in the subcortical system. This purple line shows the attentional network attaching different areas of brain. Now we will see the orienting system. It is more dorsal system, including frontal eye field and interparietal surface. Here in this diagram, this yellow portion shows the frontal eye fields, and this is interparietal sulcus. Breaking the focus of attention on an invalid trial involved the temporoparietal junction, as we will see on the further slides. Then anticholinergic drugs injected into the parietal lobe have larger effects on the ability to shift attention. The temporoparietal junction has been associated with perspective taking, that is thinking about the intentions of others and consequences to others. The third and the last system is executive system. This system consists of two networks depending upon the anatomical region involved. First, we will see the frontoparietal network. It involves the region as shown in this diagram. First is precuneus, as shown in this blue region. Medial cingulate cortex, dorsolateral prefrontal cortex, as shown in this yellow region. Dorsal frontal cortex, interparietal sulcus, and inferior parietal lobe. It is associated with starting or stopping a task and movement-to-moment monitoring of tasks, resolving conflicts, and task switching. Second network is cingulo-opercular network. It basically involves the anterior cingulate cortex, as shown in this diagram, this area, this anterior cingulate cortex. It basically, this network helps in maintaining ongoing task performances. Now, neuroimaging. Functional neuroimaging techniques that are used to study the attentional networks are functional MRI, event-related potentials. Results suggest that an attentional network activates the three mostly separate attentional networks. Now we perform different types of tests to detect the efficiency of these attentional networks. First of all is the flanker task. This basically tests the executive system. In this test, two flanker arrows are presented on both right and left side of the central target, as shown in this diagram. These are flanker arrows. In this, it is of two types: congruent, that is of pointing in the same direction, and incongruent, pointing in opposite direction. In the first diagram, it shows the congruent trial with all the arrows pointing in same direction. And in the last two diagram, the middle arrow is pointing in opposite direction. These are incongruent trial. Basically, what happens in this test, we ask the subject to click the right button if he sees the direction of the arrow as right, and left if he perceives it left. Next test is Vinconce's card sorting test. In this, we give a deck of cards to the subject, different kinds of deck according to the shape, like this. It shows triangle, star, circle, square, or depending upon the color, it is red, green, yellow, or depending upon the number of figures, that is 1, 2. And we ask the subject to sort it out according to the criteria. If there is lesion in dorsolateral prefrontal cortex, he will not be able to sort out according to the given criteria. So this helps in making out the lesion involved. Now, other test is true task. In this, two type of tests is performed. First is congruent, where the font is written in the same color as it means, and in the incongruent, the font is written in different color, but the meaning is different. So we ask the subject to read it out, read out the color of the font. If there is in the attentional network, he will not be able to read out this. Last test, next test is Posner-Kuhn task. This helps in focused on the ability to prioritize sensory information by selecting a location or modality. Measures the validity effect, that is invalid reaction time minus valid reaction time, measures the cost of an invalid cue. Evidence that not cued location are actively inhibited. So basically what we are doing in this test, in this valid trial, we ask the subject to locate the position of the target. By giving the hint or cue in form of this arrow, we suppress all the other areas by inhibition, and patient attention is focused only on this area as shown by the cue. So when we present with the target, he is able to recognize it as in this position. But in invalid trial, when we challenge the brain with a conflict, we will give the clue that the target will be going to be present here, but in actual situation, the target is present. This will create a conflict in his brain in orienting this situation. These two tests are performed for testing the alerting system. First is the vigilance task test. that is also known as toning alerting. In this test, subject is asked to press a buzzer whenever he sees a flashing light or numbers on the screen. So basically, in this, he's not able to pressing the buzzer, as seen in condition in which the alertness of brain is decreased, as in prolonged sleeping, chronic deprivation of sleep, or in sedation, any kind of sedation. Second is queuing task, as seen in previous slide. This one is also helpful in knowing the alerting system. Then psychiatric disorder. Attentional network test is useful in evaluating the attentional network abnormalities. They are useful in ADHD, schizophrenia, borderline personality disorder, stroke, and brain injuries. So we will see one by one. First is ADHD. Appears to be related to dopamine pathways from subcortical structures to frontal lobes. There is deficiency in the executive network in this type of disorder. Treatment with methylphenidate, that is Ritalin, elevates symptoms. The drug is a dopamine reuptake inhibitor. Alerting network is useful to distinguish between different forms of ADHD. Second is schizophrenia. It is highly in executive network. Smaller but alerting network. Borderline personality disorder. There is deficiency in executive network in this disorder. Now, heritability. As neuropsychiatric disorder are heritable, potential genetic factors may also influence attentional network. Executive networks are highly heritable. Alerting network, modest heritable. Orienting networks are not heritable. In genetic analysis, attentional network test can also serve as an endophenotype for genetic studies on attentional networks. Combining genetic analysis and functional MRI is a promising approach to provide anatomical constraint on the role of candidate genes that are implicated in various neuropsychiatric disorders. Now we will see different kinds of drugs which affects the attentional networks. First is nicotine. Withdrawal associated with reduction in vigilance, that is attentional network. Second point is nicotine improves stroke performance but reduce orienting on attentional network test. Second drug is modafinil. It improves attentional control via prefrontal networks. Significant improvement in methamphetamine users are seen. Third drug is Adderall and Ritalin. They improve symptoms in ADD or ADH by increasing executive control, primarily dopamine and non-epinephrine enhancing drugs. Last drug is marijuana. Chronic use in adolescents associated with more errors in executive control, but functional MRI showed increased activation in prefrontal cortex for users. Shows users have had less efficient executive control. This diagram is a summary of all the anatomical structures, anatomical and chemical modulators involving in alerting, orienting, and executive attention networks. So first is the orienting system. Its function is to orient. Structures involved brain structures are superior parietal, temporoparietal junction, frontal eye fields, superior colliculus, and the modulator is acetylcholine. Second is the alerting system. It involves locus coeruleus, right frontal, and parietal cortex. Modulator is norepinephrine. And third and the last is the executive system. Structure involving here is anterior cingulate, lateral ventral, and prefrontal basal ganglia. Modulator is dopamine. References. This data has been taken from the theory given article given by the Fan and Posner.
So you
Thank you.
Alertness is a lateralizing. It is lateralized to right front.
Yes, sir.
Over to the first slide. That is most important. All of you need to know this. Diagram either of first or the last reading can be separated. Because that is what is a top-down control and बॉटम अप कंट्रोल, बॉटम अप अटेंशन कंट्रोल होता है, टॉप डाउन अटेंशन कंट्रोल। बॉटम अप मतलब कि पेरिफेरल इंफॉर्मेशन आ रही है, यू आर स्प्लिटिंग योर सेंसेस, दैट इज बेसिकली बॉटम अप, देयर वेयर योर अटेंशन एंड ओरिएंटेशन विल or alertness and orientation will happen. So something comes to someone shows an object immediately, so alerted and oriented towards that object. And that is in bottom up. And then when you execute, then that is a top down. When you are actually executing to the brain and actually sending information to the peripheral senses, EMS, and then subsequently acting. That is why all these attention processes, we see delirium being there. This right frontal alertness on where you have got this last slide taken.
Sir, which one last summary?
Awesome. This reference to this right frontal alertness. This table you taken from there.
Sir, Google. I have taken.
Google. No reference. Need to check it out. The right frontal defines alertness. So left frontal doesn't define alertness. Then which part of the frontal it defines? There are many parts of the frontal.
Yes, sir.
Zoom is being recorded or
Good morning, all. So I'm going to present insight today. So what is insight? It is the conscious recognition of one's own condition, or it is a person's capacity to understand the nature, significance, and severity of his own illness. Now, why do we need to know about the insight? So psychiatric disorders were classified on the basis of psychosis and neurosis. In psychotic disorders, insight was absent, and in neurotic disorders, insight was present. It was also seen that in psychotic disorders, hallucinations and delusions are present, whereas in neurotic disorders, hallucination and delusions are absent. In psychotic disorder, reality testing is absent, whereas in neurotic disorders, reality testing is present. So here I would like to tell you with an example. Suppose a patient of schizophrenia, he's having a psychotic disorder. He will not come by himself. He will be brought by his relatives. Whereas a patient of neurotic disorder, suppose a patient of PTSD or anxiety, a patient of anxiety, he will come by himself and he will tell you that, sir, I'm experiencing these symptoms and I'm experiencing these flashbacks. So he will have the insight, but a patient of schizophrenia doesn't have the insight. Or sometimes, now we don't use this classification because sometimes psychosis and neurosis overlap. What is impaired insight? It is the diminished ability to understand the objective reality of a situation. A person with poor recognition or acknowledgement is referred to have poor insight or lack of insight. The most extreme form of impaired insight and also nausea, that is total absence of insight into one's mental illness. What are the factors influencing insight? Cultural mood of illness, general intelligence and knowledge, the doctor-patient relationship, the symptomatology, the preservation of self-esteem, avoidance of stigma in the society, and the patient's personality. So I would like to call Dr. Ria to illustrate the grading. Do you have any disease or are you experiencing any symptoms? This is grade 1. There is complete denial of illness. Do you have any disease or are you experiencing any symptoms?
Sometimes I feel but I'm low.
So this is grade 2, where she is accepting and denying at the same time. Do you have any disease? You are having any abnormal symptoms? So this is grade 3, where she is attributing the symptoms to some external or physical factors. Do you have any disease? So this is grade 4. She doesn't, she accepts the disease, but she can't explain it properly. Do you have schizophrenia? So this is grade 5. This is intellectual insight where the patient accepts that he has a disease, but she will not change her behavior according to it. If I ask her to stop smoking, she will not stop smoking and she will not take the treatment. So this is grade 6.
Grade 5 and 6 still what she has put the answer is not. Doctor is like a father figure for it. I will take that and myself. Maybe the doctor doesn't listen. I will go for so that is clear. She's obviously having a
So how do we assess the patient? We ask these questions. Do you believe that you are experiencing any symptoms? Do you believe that these symptoms are related to any illness? Do you believe that the illness is psychiatric? Do you believe that psychiatric treatment might benefit you? Will you accept the treatment from the doctor and change your behavior according to it? Lack of insight can be correlated with worse outcome, more admission, worse psychosocial functioning, reduced success rate and relapse, longer interval between onset of symptom and seeking treatment. Now, suppose a patient of schizophrenia comes to me and I put her on antipsychotic and I sent her home after some time. After some time, because of lack of insight, she'll stop taking the treatment and the disease will relapse. Now, Indian, this is a question for all. Out of 10 lakh COVID positive cases in India with complaints of cough and cold during the third wave, 2 lakh people said that they left the window of their room open last night. So they developed the symptoms. 4 lakh people said this is happening because of the change in weather. 2 lakh said this is because of children they had in the last party. So what grade of insight do all these have? It is grade 3. Why? Because they accept the disease. They accept that they are having symptoms, but they are attributing them to some external or physical factor. So insight is not just for psychiatric disorders. We see every patient. We ask our parents, are you having any fever? They'll say no. तो कल रात को हमने खिड़की को नहीं छोड़ दी थी, आवाज हो गई. So this is it. Thank you.
how do you say it?
So they accept it. Yeah, they accept the symptoms. They accept that some illness is there.
Word नहीं है. In cold, COVID is different. But we You see, insight of having it viral, insight of having it COVID.
Good morning to one and all. Today I'm going to present on the topic judgment. My moderator is Dr. Priyatali. What is judgment? Judgment is a complex mental process whereby a person forms an option, makes a decision, plans an action or response after analyzing the issue and comparing the choices with the acceptable social behavior. It is mediated by the frontal lobe of the brain. It is an act of comparing and evaluating a proper course of action. It includes the concept of ethical values and insight in its meaning. Judgment underlies decision. A meaningful judgment first requires appropriate insight into one situation. Assessment would take into account the individual's executive system capacity in terms of impulsiveness, social cognition, self-awareness, and planning abilities. Traditionally, the MSc included the standard hypothetical questions. However, contemporary practice is to inquire about how the patient is going to respond or would respond to real-life challenges and contingencies. Impaired judgment is not specific to any diagnosis, but may be a prominent feature of disorders affecting the frontal lobe of the brain. If a person's judgment is impaired due to any mental illness, there might be an implication for the person's safety or the safety of others. Now, what is the difference between insight and judgment? Insight denotes looking in, whereas judgment denotes looking out. Insight is the self-appraisal and self-esteem, whereas judgment is the appraisal of major social relationships. Insight is understanding of current circumstance, whereas judgment is understanding of personal roles and responsibilities. Insight is the ability to describe a personal, psychological, and physical status. Now, the types of judgment. There are three types of judgment. First is the social judgment. Here, the person's interaction with the social members and the interviewer is assessed. It is usually assessed from the history given by the informant. Second is the personal judgment. Here, the individual's personal expectations, plans, and attitudes are assessed. The next is the test judgment. Here, we assess the course of action that a person might take into socially difficult or disastrous situation. Now, how we evaluate judgment. Judgment must be examined in the context of patient's recent behavior, intelligence, memory, and other cognitive functions, diagnosis, and the treatment adherence. Judgment can be rated as intact or impaired. Direct questions about judgment attempt to determine whether the patient is aware of what normal social interaction or responses are. I would like to request Dr. Shubham for the illustration of the test judgment. I'm going to ask you quickly. Suppose you find a letter, stamped, addressed letter on the road. What will you do? So this is a response of a normal person. A person suffering from mania will say that I will start reading that letter there. And a person suffering from schizophrenia will say, I will not open that letter because it may contain a chip. So the next situation is you are in a building and that building catches fire. So what do you do? So this is a response of a normal person. A person suffering from mania will say that I myself will extinguish that fire. And a person in depression will say that I cannot do anything, I will die. Suppose you are traveling and you see a man lying on the road after an accident, and what will you do?
And I will ask the people to.
So it is the response of a normal person. A person suffering from mania will say that I myself will take that person or I myself will treat that person. A person suffering from schizophrenia personal judgment. Suppose person suffering from mania will say that I will go and I will become the Prime Minister of India. And person suffering from schizophrenia will say that I will not do because my family members will kill me. So this is how we test it. Thank you. These are my references.
My only my only issue is why you doing in English. Why not in Hindi?
Because he understands English.
And how you differentiate personal judgment from psych?
So personal judgment is how the person, so his plans and his attitude are judged. It is the personal judgment. And whereas inside, so it denotes inside self-appraisal and self-esteem.
Psych is impaired. When the personal judgment will also be impaired.
Yes, sir.
Because the rationale of choosing among various options
Yes, sir.
will be impaired because of the illness. Then we'll talk about in context of a major mental disorder like schizophrenia, it will be impaired. When we talk about minor mental disorders or like depression, anxiety, it might not be impaired. To see, because generally when we take a presentation, if you make insight is grade 1 and all the domains are intact in schizophrenia, it will be taken with a pinch of salt and will be asked to demonstrate. Then it will be a little difficult because personal judgment also you're saying that your plans, how you go, will you take treatment, because there is no insight how the patient will not respond to it. Very simple, basic point, but it is very important. They are the monitors. Situation needs to be and two shops away from you has called. The patient will reply differently. Because I have been sitting this one, this one. Definitely I will try to first have an answer and then I'll see how can I see what it is. Until as I'm not an army person or I'm trained. Very importantly, one more point is villages, what situation will they don't have a fire station. Usually, in villages in remote areas. What situation will you do for judgment? One is that chitti, that is very apt because the still communication levels there. I don't know in share in city how many of us would still like chitti. So, so in villages, maximum villages have wells. So कोई बच्चा कुएं में घुस गया क्या? Very isolated concrete situation, and then about how they respond. Generally, we will get those. So situations given should be very clearly elucidated. आपने अगर से abstract situation दिए तो उसका judgment नहीं आता. What behavior? What behavior is generally comprised of patient's interactions with the family, with the patients, with the PT team, with the nursing staff. And what behavior, real inputs you will get it from nursing staff. The exact input of the nurses because they're in touch with for a period of time. That is why in rounds we actually make a point that nursing staff should accompany the rounds and give her his or her inputs. Very well presented. All three of them. I would say all three of them presented like they're presenting it for n number of times. Professional presentations. And the demonstration. It needs a lot of courage and confidence to demonstrate something like that. At least in insight, they could go with one question or answer and make it more or less very clear. Inside investigation is not that simple. More deep narrative approach to listen to say. Good.
बड़ा सही लग रहा है कि हमारे इसमें साइकोलॉजिकल न्यूरो ये बताया कि साइकोलॉजिकल होता है ये तो बड़ा होगा हमारे जिसको बड़ा
Tomorrow, which topic we have?
Dance.
And who's presenting? And today's case conference, 2 o'clock. So we start at 2 o'clock. Thank you.